Okay, well, why don't we get going? We're at the top of the hour. So I have the pleasure again of welcoming everyone to today's Berman Institute of Bioethics seminar. As we do every 2 weeks when we have these seminars, we will have an opportunity to have speakers join us from this time from the UK and from Kenya to present. We'll have about 45 minutes or so of presentation, followed by an opportunity for some discussion via the chat or Q&A. If you would like to speak, we very much would welcome that. You're welcome to raise your hand or type a note in the chat and let us know that you'd like to make a comment, and we'll be able to add you, allow you to talk. Otherwise, I think we'll probably just get ourselves going today here, and I'll start myself by introducing our two guests who we're very much grateful to have joining us today, and they're Professors Sassy Molyneux and Dr. Dorcas Kamuya. I'll introduce both in turn. So Sassy is a professor in global health based at Oxford and a senior researcher at the Kemri Wellcome Trust Research Program in Kenya, where she's been based for 28 years. She's an interdisciplinary researcher with backgrounds in human geography and behavioral studies, has done a ton of really interesting and important empirical work on different issues involving ethics and social science in health systems, including issues of governance and finance and responsiveness to patient and public priorities and needs, as well as treatment seeking. I found your work, Sassy, on sort of microprocesses in health systems to be really, really interesting and valuable, especially in the context at Kemri and in Kenya. And I know over the many years, we've had many of our own Fogarty trainees and alumni get to know you a little bit in their own work and benefit from your scholarship. So very grateful for having you here today with us to share some of your work, and to be joined by your colleague, Dorcas Kamuya, who's known by many. And Dorcas is a Wellcome Trust Society and Ethics Fellow and current head of the Health Systems and Research Ethics Department at Kemri Wellcome Trust Research Program. Her fellowship research is in empirical ethics and examines how communities could be engaged on complex ethical topics, with biobanking as a case study. As a social scientist researcher in Kenya, her research interests span several interrelated areas. So she's done work on ethical and social cultural issues around emerging technologies, such as biobanking and machine learning, the value of community and public engagement in health, ethical dilemmas for frontline research workers, and responsibility of researchers and research institutions conducting research in resource-limited contexts. As I mentioned, Dorcas is based at Kemri in Kilifi, where she is right now, and is a member of a number of different global health and ethics networks, and has contributed both through scholarship and her service to those groups. So with that, I think we have enough background, I think, to jump in, and we're very delighted to have Sassy and Dorcas speak on strengthening ethical practice at the front line of global health research, reflections on opportunities and challenges. So over to you both. Thanks.
Great, thanks so much, Joe, for that introduction. And what Dorcas and I are going to attempt to do is a bit of a double act on this, to share some of our reflections around some of the interventions and some of the research that we've done around efforts to strengthen ethical practice in doing research in settings like Kenya. We've attempted to embed two videos, an animation and a video in this presentation, so fingers very crossed that everything goes smoothly for us technically. So what we're hoping rather ambitiously in this presentation to cover is these three sort of main interrelated areas in the center of this slide. So we're interested in the ethical dilemmas that are faced by frontline staff, and by frontline staff, we mean the people who interact with participants, with health workers, with community members in the conduct of research. We're interested in understanding their ethical dilemmas, in the kind of support processes that are introduced to support these various cadres of staff, and also in public and community engagement processes. And all of these areas interact with each other and are shaped by depending on what exactly is being discussed, the specific study design and how it's set up within institutions and communities, the broader history, policies and procedures of the institution or sets of institutions, often in international collaborations, that are involved in the research, and also the broader power dynamics and inequities that are involved in the architecture and the conduct of global health research. So we're hoping to touch on all of these areas in this presentation. We'll be drawing very heavily on our research and experience at the Kemery Wellcome Trust Research Programme. I'm not sure how many of you are familiar with this programme, but it's a large programme, and it's one of many under the National Kenya Medical Research Institute in Kenya. The programme itself has a large proportion of its funding from the Wellcome Trust, which contributes to its name. It's multidisciplinary, bringing together clinical researchers, epidemiologists, immunologists, various different social scientists. And it's large. It grew from about, in the early 90s when I first went, about 15 staff to more than 750 now, with the majority of those staff at all levels, including the most senior, being Kenyan. It's an international programme of work, though in its reach, and there are many international collaborations contributing to the programme. So although we're drawing primarily on our experience at the Kemery Wellcome Programme, we've also learned so much from various different international networks and collaborations that we're part of. And one of those is the Global Health Bioethics Network, which includes researchers, ethicists, community engagement personnel, social scientists based in centres in South Africa, Malawi, Oxford and Ethox, Thailand, and Vietnam. Another really important collaboration that we're part of and that we've learned from is REACH, which is a Wellcome Trust funded collaboration led by Maureen Kelly. And this has been recently completed, and we were looking at trying to better understand researchers' responsibilities in the context of vulnerability. What we thought we'd do to start this presentation was actually to show you an output from this REACH collaboration, which was first put in the public domain last October, so October 21. And this really, here's from the point of view of frontline research staff, field workers, their perspectives on conducting research. So here's hoping that this video works, and I think it speaks for itself in many ways.
We are the frontline research staff. We are the people who gather data, take samples, speak with participants and their families, carry research messages through public engagement events. Some of us are senior in our research institution, some are not so senior. But what makes us similar is that we visit people's homes, and sometimes we even land up sharing meals with them. Often, we are working in our own neighborhoods, in our own communities. We listen to people's stories and struggles with interest, concerns, and sometimes sadness, because these are stories that we know very well. We often land up being the face of research in communities and a bridge between researchers and communities. We have a lot of knowledge to share and face many challenges. Many of the challenges we face are to do with what should we do, what are our responsibilities in the community. These are really often difficult ethical or moral problems for us.
Research is often done in places with a high burden of disease. but also where there are many other health, social, political, or environmental challenges. There may be a drought happening, water shortages, protests around a political election, or staff strikes. In Kenya, communities were facing many of these challenges during our research, including a huge national nurses strike.
Here in Mesot, along the Thai-Myanmar border, migrants who join research on malaria and pregnancy are also sometimes living in fear of being discovered if they do not have documents. The roads and bridges may be blocked or become unavailable because of flooding, making it difficult for people to get to a research site, which is also where they come to the clinic for care.
We also see so many difficult journeys. Frontline staff also often have to cross the river in high waters during rainy season.
So the biggest ethical challenges facing the frontline staff are around wanting to help people directly when research results may not happen quickly and the benefits may not come for many years. Sometimes I wonder why we are gathering data when what I want to do is to help people directly by providing care or medicine, something that is needed today. I realize it is important to develop better health interventions, but then I wish we could do more now. We need more support in responding to ethical challenges in our day-to-day research in our context.
Something that often struck me in my interactions with families in a very low-income area of Nairobi was how much young mothers went through to try to get their babies treated or to keep them well and restore their health. So they would try to access money, which was often not easy. They would seek advice from various networks on what to do, and this included their in-laws, parents, their neighbors, friends, sometimes negotiating with their own spouses. And all of this was happening in what were very often difficult living environments.
Here in South Africa, HIV has been a serious health burden, and so it remains a major research focus. But there are so many other health and social problems that we see people struggling with. Despite the challenges communities face, they show strength and are resilient. It is important not to label people as vulnerable or use stereotypes because this can mask their unique needs and inadvertently exclude them from research that could benefit them. For example, labeling adolescents as vulnerable to HIV may stigmatize them and hinder participation in HIV research. We also see examples of young people's agency. For instance, they portray themselves as proactive and being agents of change in the community whilst managing the HIV disease. So their inclusion in research is important to inform context-relevant research and interventions which support their agency.
It is incredible to see how families and women will work so hard to provide for their family and make difficult journeys to seek care and to participate in research. People sometimes think that young people or women do not have power to make choices in their lives, but they do. There was a young girl, she was 16, and she joined a study because she said she wanted to gain more knowledge, she wanted to learn more.
So our question is, how can we work together with communities to make sure research priorities align with what matters most to the community? As frontline researchers, we offer a valuable perspective and bridge to understanding people's needs within research and beyond in their day-to-day struggles. But we also struggle in knowing how best to respond to the many dilemmas of care that we encounter in our work, and we need more support.
We hope that by raising our voices, research leaders, institutions, and funders will hear us, and we can work together to ensure that research remains a tool for improving lives for everyone.
So I think that video hopefully speaks for itself really, but just to highlight a few points is that frontline staff really do play diverse and important roles in conducting research, and in the conduct of that research, often they're interacting with stakeholders and participants who are experiencing a range of complex and layered sources of vulnerability. And in that box in this slide here, there are illustrations from that video of all of these different types of sources of vulnerability. At the same time, those stakeholders and participants also have agency, an ability to make choices and to exercise decisions, although that agency may well be constrained by those sources of vulnerability themselves. And this interplay between layers of vulnerability and agency are brought into research encounters and impacted upon by those encounters. And in this paper by Scholar, there's a detailed example of how this happens in relation to one of the case studies of the REACH collaboration in Kenya. And we'll come back to this particular case study later in the presentation. And clearly, frontline staff face many dilemmas when they have interactions in these contexts that they need more support with. And so from that video and more broadly across the REACH collaboration, there are a number of really essential justice concerns that are highlighted. One of them is that it can be tempting to avoid doing research involving vulnerable populations, so-called, because of some of the ethical challenges and worries about doing that research. But it's also highlighted that it's very important to do well-designed research with these populations in order to better understand their lives and situations, including from their perspective, and also to be able to, on the basis of that understanding, contribute to transformative, positive interventions and new ways of doing things. Another justice concern is that when research is done with these types of populations or groups, we need to be really careful that the research processes and procedures that are involved don't add to those burdens. And also that agency is recognized, that it's protected, and that it's ideally promoted through those processes and procedures. And clearly shining through there is the need as a justice concern for greater recognition and support of the roles and contribution of frontline staff. And processes are needed to be able to hear the voices of these staff, especially in those really large research programs that have many staff members, and to be able to respond to what's heard and to the concerns that are raised, including in relation to basic issues around, for instance, career structure and levels of pay. So having given that broad overview of some of the key highlights and heard the voices from the people that were involved in the research, the REACH collaboration, we just wanted to turn now to institutional policy and practice more specifically at Kemry Wellcome Trust. And perhaps to turn back a bit in time and to just reflect on where some of our interest in those three intersecting cogs in that early slide came from. And in the late 90s, early 2000s, I was involved in leading a study that was basically doing some quite detailed work. Joe, I think, referred to some of this work, looking at what community members thought of the research program and how consent processes were working. And I remember it being pretty terrifying at the time to be reporting back to our funders that Wellcome Trust was funding this unit interaction study, to say that consent processes weren't actually working that well in terms of the kind of textbook ideas of how consent should be working. There was a lot of very positive things being said about the research program, but not really describing it as a research institution. And there were a whole range of issues and challenges highlighted as well in relation to communication issues, but also in relation to differences in resources and what resources could be used for within the health system and the research institution and research systems. And this slide here is from a presentation in Brazil in 2002. And it was really highlighting there key role that field workers play at the interface between these research systems, community systems, and health systems, and that this role is often under-recognized and needs greater support. So that study, but also just the growing size of the research program in Kenya, contributed to policy and practice change around community engagement and field worker training and support. We'd always been doing community engagement activities and training of field staff and interface frontline staff, but it became clear that it was important to have a more institution-wide strategy with some more strategic thinking and planning. And Vicky Marsh and Francis Kombe came in to really help lead that and drive that thinking. And we're really delighted that at that point we employed Dorcas Kamuya to help with that whole process as well. And Dorcas was working in participatory development in the coast at the time. And she helped us to develop a community engagement strategies together with stakeholders, local stakeholders in the area, including community representatives. And the work was designed essentially as a form of action research. So to be constantly implementing, learning by doing and evolving what we were doing. And that's continued to this day. And so I'm going to attempt now to hand over to Dorcas to tell us a little bit more about that work.
Thank you very much, Sassy. So building on the background and the nice information that Sassy has provided, we set out our engagement strategy with quite expansive goals. And these goals have largely been evolving over time, informed by the action research and what we are learning. And these are the three broad goals we are currently working with. One of it, the first one, focused really on the type of relationship that we are building with the communities wherever we are working, to look at not only mutuality and understanding, appropriate levels of trust and respect, not only with the communities, but also between the researchers, the institutions, and the communities, wherever we are, wherever our researchers are. The other one, a core one, is also enhancing the ethical conduct of research anywhere in the world where Cambridge researchers are working, and improve. What became more obvious over time is that we needed, and based on the feedback from communities, to focus on how we are disseminating findings, not only to community members, but also to policymakers to make impact or to make changes in healthcare, in health systems. Next slide. And so our research and our engagement is in diverse settings and in diverse contexts. And in our engagement work and in supporting our frontline workers, we recognize that we are working not only in very rural populations, but also in urban settings like Nairobi, where the contexts are so different that the needs are also likely to be quite different, as well as in other settings like Mbale. These are the core hubs of the program, but with our work across many other populations. And our engagement activities are therefore tailored to fit within the populations where we are. We broadly see as a spectrum of engagement, right from very broad public engagement kind of meetings where if there's less participation, it's more like media, more for information sharing, to more deeper engagement where it's participative, we are actively seeking opinions, there's deeper learning, there's co-sharing, there's co-creation of what we are learning. And in the latter, because of that depth of engagement, there's likely to be less representation of people, so working with a closer group of community members. Next. And so generally structuring our engagement around areas or issues or institutional policies that are at what we call institutional level or macro level, as well as thinking about very specific studies and the requirements of those studies when it comes to engagement. And so we have engagement that talks about Cambridge, and we're listening and learning about our work from populations, but also engagement that talks about specific studies and sometimes quite in-depth consultations on the research design, the research questions, the findings from that research, and throughout informing policy and practice within the institution as well as for studies. Ongoing feedback is part of that engagement, right from community, from our staff who interact with communities. Scientists are part of that. And we have, like we said, it is action research. So within it, we have integrated evaluation within our engagement activities. Next slide. This and a very core group in this engagement is obviously the field workers. Field workers are the frontline staff that are often interacting with the communities, seeking consent, explaining about studies. And as part of supporting them, we have training programs that on communication, on consent, on how to deal with difficult situations that they might face on the front line. Importantly also, it's not just the field workers, making sure that the researchers themselves do go to the communities, do talk with the people, with the communities, the populations where their research is. So they have a real sense of understanding of not only what the frontline staff are going through, but also the populations where their participants are coming from. And that is part of the studies that we do. In addition, we are carefully studying about our engagement work. And we have pulled on engagement or used engagement approaches to inform us on our policies and what we need to be looking out for. And there are quite a number of papers that we have written about this, including consultations on some of the really difficult areas like benefits in health research, data sharing, policies. I talked about in my work, I'm looking at biobanking, and we're not only talking to researchers, but also to the communities and really using deliberative forms of engagement to get that in-depth understanding. Next. And our social science research is not only on community, but also on the frontline staff. Empirical work carefully designed to understand the issues that they face at the front line of research. In my PhD was focusing on ethical dilemmas for frontline workers, and it helped us unpack some of the dilemmas. One which I've written about is what we call silent refusals, and through that PhD, I tried to unpack what this phenomenon is and how it arises. What we realized is that in the population where most of our work is happening in Kilifi, populations or people are quite polite. They don't often say no, even when they would want to say no, and there are many reasons. So try to understand why that arises in research, but also importantly, how field workers were encountering this and what they drew on and what was not available for supporting them was helpful in us as an institution, making a policy around how research and field work, frontline workers ought to be supported, and to be able to raise issues that they might face in the field with the PIs. Next. So having talked about the community engagement as a very key element and the research that is going around it, an area that we realized often and we are very keen to learn from is how our engagement is making a change, whether what effect engagement has had. Not only ourselves, but there are many people who are interested in the evaluation of engagement. We were lucky to have been funded by Wellcome Trust to carry out a reality review with colleagues who have been looking at evaluating engagement across diverse settings. And this literature review that is already out, has been published in the Wellcome Open. There's a long paper that you can read, has been very helpful in us understanding the key elements that make engagement really powerful. We used in the reality review, we used malaria research as a tracer element to understand community engagement across diverse settings and in low and middle income countries. And most of the papers, they were coming from our settings, obviously, because we've written quite a lot about it, but we also did learn from other settings. And we had sharing the findings of that through several publications. This is a paper I've just mentioned. There are policy briefs that somebody can quickly look at and see the key findings. One of the policy brief obviously is targeting frontline researchers, community engagement, research institutions, but also another is really looking at funders and what is it that we require from funders when it comes to supporting engagement. We have also developed as part of this wider sharing an animation video, which we are going to play shortly, This animation video summarizes the review that we did, the reality review, and the key findings from it. In recent years, there's been an expansion of community engagement in health research as its benefits become more widely seen and understood. Community engagement is also known as community participation or public and patient involvement, and it is often understood as a range of activities that it encompasses, such as community meetings, setting up advisory boards, or involving local stakeholders in the design of interventions. However, what community engagement is and how it works in practice is far more complex than it might first appear. A review of published papers on community engagement in malaria research trials in low and middle-income countries highlights its role in enabling the development of precarious working relationships between researchers and local stakeholders. Rather than any specific engagement activities, it is these relationships that lead to greater acceptance and participation in the research by stakeholders, even though their motivations differ from those of researchers. While researchers may aim to produce high-quality research, in countries with under-resourced health systems, a primary motivation for local stakeholders to participate in the research is the accompanying benefit of access to healthcare. So these relationships rely on the exchange of tangible benefits by both researchers and participants and are built and maintained over time by respectful and considerate interactions. There are also wider contextual factors that, while not always visible, are powerful in shaping relationships. For example, behind the interactions can be important differences whereby senior researchers who are employed by universities or research institutions are in a position of relative wealth and power compared to many local stakeholders. In settings with high levels of poverty, the exchange of healthcare for research participation may leave people little choice but to enroll in the research, despite any concerns or misgivings, sometimes called structural coercion. The fact that high-income countries fund and control much of global health research can also undermine relationships, as local stakeholders may have less sense of control over the research. This may contribute to research not reflecting local priorities. Overall, the findings suggest that while the development of working relationships between researchers and local stakeholders helps to get research done, these relationships may rest on ethically problematic aspects of the way much global health research is typically carried out. If this is not acknowledged and challenged, there is a risk that community engagement entrenches rather than changes existing inequalities. To address these ethical challenges, researchers and funders must pay greater attention to the relational dynamics of engagement and consider wider contexts that influence these relationships. More structured support of frontline research staff by research institutions would help them navigate these relationships, but the wider context also needs to be addressed. Recognizing that access to healthcare is a primary motivation for research participation in some contexts suggests a need to consider how the infrastructure of health research could proactively support health systems in these settings. Relationships built through community engagement should complement and feed into engagement with health policymakers and managers to expand local ownership of health and research agendas. Ultimately, community engagement has the potential to help improve connections between health research and health systems and strengthen the ethics of research. So coming from that reality review, we make several recommendations. One focuses on how community engagement enhances building relationships, including looking beyond simply the specific research timeline and thinking about more over long-term relationship building. The other one is focused on evaluation that we've started talking about, that we need to be explicit about the assumptions we made of our engagement activities and programs, what theories of changes we think we are planning our engagement around, and also look at the broader ethical and political focus and how engagement can inform and build on that. The health research should maximize opportunities to strengthen health services and systems, and this could be through co-creation and co-design with some of the key stakeholders in healthcare system. That way you have not only a broad buy-in of the research, but also that research that is relevant to the population, to the health systems, and that is useful and impactful. And finally, we also talk about the need for frontline research staff and institutional support for both frontline research staff and engagement staff, including considering program-wide engagement. Of course, I hand over back to Sassy.
Thanks, Dorcas. I warned you we were trying to do a bit of a double act here. So yeah, thanks so much, Dorcas. So back to sort of the topic of institutional support for frontline staff. And I mentioned earlier on about the importance of basic issues that these cadres of staff often face. But a really key issue that we dug down a little bit more into as part of REACH was on support processes for dealing with these really tricky everyday ethics dilemmas that are faced. And just to show a little bit more about this, I just wanted to talk some more about one of the case studies in Kenya from REACH. So this was called CHAIN, and this is a hospital-based observational cohort study centered around 9 different hospitals in different LMICs, 3 in Kenya. And the aim was to try to ultimately reduce mortality of children post-discharge from hospital through better characterizing the biomedical and social risk factors that contribute to poor outcomes, and using this information to identify really targeted interventions. So this is a multidisciplinary project, and it included embedded ethics work and social science, where we talked to family members of children who were involved in the cohort and understood the treatment seeking, or learned about the whole treatment seeking journey from their perspectives. We also held interviews with researchers and with hospital staff to hear about their views about the research and interacting with these families. It's important to mention that there was, of course, a lot of careful attention to ethical issues in conducting and designing this study before, as part of the approval process. In Kenya, the CHAIN studies benefited from the platform of work that Dorcas has outlined already in terms of support for community engagement for benefit sharing, institutional policies based on local inputs, and so on. In terms of more specifically for this particular study, the local, national, and many international ethics and science committees agreed with the need for an observational study. And there were very carefully designed and continuously reviewed referral and auxiliary care plans organized for the study. Despite all of this careful thought, and unsurprisingly in many ways, we heard about and experienced ourselves a huge range of ethical challenges in the day-to-day conduct of this study, as we've seen with many other studies in our environments. And along the bottom in these bubbles here are just some examples of the many different things that we heard about when talking with colleagues or when talking with household members ourselves. Just to highlight 2 examples for in the sort of orangey one there. Very, very small differences in many, in many perspectives, in types of compensation between people in a similar environment and slightly different studies, was causing a lot of irritation and confusion amongst family members and leading to lots of questions being asked of frontline staff. who would often worry about why can't this just all be streamlined. A very different sort of example, one clinician mentioned to me, a clinician from the local community, that when he was asking a mother about what nutrition there was in the house, which was part of the research tools, he said he just looked at her and there was just a tear going down her face. She couldn't respond. There's so many of these very emotionally charged interactions that frontline staff have, and the questions are about what to do, what's my responsibility to act, where does that responsibility end, and what's the impact of my actions on others around me. So we realized early on that we needed to establish opportunities to discuss these issues, not least because many people were saying that they didn't want to raise these issues within the research hierarchies because they was worried that they might look like they were incompetent or they should know how to deal with these issues. So it took a lot of careful setting up to organize a series of meetings and lots of support from Maureen Kelly. So huge thanks for that. But these were meetings that were aimed at being very relaxed and judgment-free, where people had an opportunity to properly talk through anything where they felt discomfort or where they weren't quite sure what was the right thing to do ethically or morally. And we evolved a tool to help us with these discussions. And the way that they tended to go was that we would have a discussion on an issue, and we would discuss what happened, what went well with the response, what might some of the alternatives be, and issues around alternatives as well. And then for each case, looking at the blue at the bottom of this slide, we'd be thinking about how urgent or serious is the issue for the people involved. How related is the issue to the research? Was it actually caused by the research, or was it revealed by the research? For instance, with that tool asking about nutrition in the home, is it part of the background situation that people become aware of? How much capacity is there for the person to be helped and for the person acting to be harmed? And who really is the best person in that context to help with this situation? And what we were thinking all of the time was about these hexagons here. What's the potential for action and at what level? So sometimes there was just nothing that we could think of that could be done, but we valued sharing the dilemma and that others heard it and recognized it. Sometimes there was more immediate action that we all immediately agreed we could do straight away, and just changing how we talked or what we said or how we behaved. Sometimes we needed to change. I'm in the C hexagon here, the study operating procedures in some way, or the benefit details. So something that needed to be changed at the study level. There were a few things that needed to be changed at the institutional policy level. And we had been prepared, if necessary, to go to the National Ethics Committee to talk about things that we felt might need to be changed at that level. But in fact, we didn't find something in this study. All of the time, we were thinking very carefully about the unintended consequences of potential actions and interventions for a whole range of different actors involved in our work. So we've written up this process that we were trying in this study to help ourselves and to help the study and to help colleagues with dealing with some of these emotional dilemmas that were being faced. And there are opportunities that we think that came from the spaces that we set up in terms of giving psychological relief to ourselves and to others, recognizing the kinds of issues and dilemmas that different colleagues are facing. And it really helped to bring to life these very detailed auxiliary care plans, the policies that are implemented through them and through other interventions, really bringing them to life and seeing how they should really work on the ground in different cases. There are also lots of challenges around this as well, though. It takes time, it takes a lot of people's different expertise, and really crucially, it takes the senior staff involved in a trial like this to really be interested in it and to be fully engaged and supportive. And a really key issue is that many of the emotional issues are simply not solvable. And the challenge remains there. What is our responsibility? And where does it end in the face of what we're often encountering, which is basically the outcome of structural injustices? And so as careful as we can be, and there are many sort of challenges with our community engagement and our frontline support processes in Kemri as in many other places, there are limits to what we can achieve. We're not able to solve through these mechanisms and approaches and historical and background injustices and inequities. And so we remain with this really big and deep challenge around how research ethics and our actions can engage with these deeper drivers of these ethical challenges that we're encountering. And I think it's challenges that have evolved over a long period for Dorcas and I and others that contributed to our being interested to be part of, with some amazing colleagues here, an exchange network to think about decolonization and global health research. And so we've recently just begun an exchange program to basically think through what can we learn from ethics, from health policy and systems research, and from feminist studies about our responsibilities in the global north, in the global south, as different actors in global health research, our responsibilities and any new learning that we might have brought by some of the recent decolonization debates on how to function in this global health architecture that was in the outside of that diagram that we began this presentation with. And so we're really at the very beginning of that exchange program and really hoping to learn from our colleagues there, including philosophers and people with a decolonization and decolonial theory expertise, which we don't have. So thank you. I think that's the end of our presentation. I think we've gone over by a couple of minutes, but over to you, Joe. Well,
Thank you very much, Sassy and Dorcas, for that really interesting and important presentation. And I see we're starting to already get some comments in the chat here, and I'd like to share those with you, as well as just invite others to offer questions or comments. And if you'd like to speak, do feel free to raise your hand, and we can call on you. So just to read these out, I think so. One comment is that there's a suggestion that we need special ethics standards in vulnerable communities and with participants and in humanitarian settings. Not sure if you've thought about that in particular, but I think largely what sounds like your work has really highlighted some of the special considerations and procedures that might be needed. And then I see Poe has also offered a comment here that I think signaling the importance of health systems, which are complex and diverse, made up of institutions and health professionals and health service providers, and low and middle countries collaborating more effectively with each other rather than viewing themselves as isolated entities. So I don't know if you have any reflections on those comments before we get into some questions.
Yeah, no, just thanks for those comments, and couldn't agree more. And I think sometimes research institutions and perhaps even specific types of research, more biomedical research programs I'm thinking about, might be thinking about some of the future gains, the things that will be learnt for the benefit of future generations, which is really important. But thinking about the interplay and the implications for health systems every day, and some of the potential negative implications of in conducting research for those systems, and the potential to build them through the research, is actually something I'm personally very passionate about. I think is really important. So yeah, thanks for that comment. I can see a really long one there. I'm
yeah,
not sure.
there's one there. which I can read out here for you. It's asking, basically pointing to the fact that if vulnerability is a key concept, and deciding or determining who's vulnerable can be challenging. And how do you think, I guess more broadly, how do you think about vulnerability in the work here, and the role that that kind of term, that concept, construct plays in your research? Yeah, so anyway, you can read the rest of the comment there if you'd like, but just, yeah.
Yeah, who decides who is vulnerable? I don't know if Miri or others would like to comment, so it'd be really helpful to get some discussion going. I think that was one of the really important points about the work that Reach was doing, is that it was important to hear the voices from so-called vulnerable communities themselves about their own concerns, their own sources of strength, and I think quite often it's the kind of labeling of which populations are vulnerable masks a hugely complex reality of vulnerability and agency, and very specific types of vulnerability for particular outcomes. And so I think the labeling is really problematic. And so that sort of links a little bit back to an earlier comment of needing to have special guidance around working with vulnerable populations. I think that is there, and I think some of that guidance rightly does and should be careful about who's doing the labeling, the problems around labeling populations as vulnerable, what can be removed by doing that, including what can be removed in terms of valuable research, because I think quite often populations, groups are left out of research because of concerns about vulnerability.
I might ask.
Dorcas, do you want to chip in?
Yeah, Dorcas, please. I was going to ask you a question,
Yes,
but you're welcome. Yeah.
I just wanted to say, just to add what the nice response from Sassy, one of the things that the research did was contribute to this framework that helps tease out vulnerability, where it recognizes that vulnerability can in itself be stigmatizing to populations when they are lumped together without realizing people are so different. Simply putting our entire population saying is vulnerable is also failing to recognize the resilience and the ways in which they work. And so one of the ways is how to unpack it, including considering what is it that they are vulnerable to, how are they responding to that vulnerability, how is their agency coming into play, the context in which they are situated. Is it simply a temporal situation? Is it a more long-term situation? So try to unpack all that becomes part of the background in unpacking what is vulnerability. And there's a very nice framework that has been published about that.
Thanks very much, Dorcas. If I could ask you maybe just another question, Dorcas, about your experiences of late with frontline researchers and community engagement in the context of the pandemic. Do you have any thoughts or reflections on sort of how the pandemic has affected them in the daily work and in the processes that are typically implemented to do that work? If you wouldn't mind sharing, that'd be really interesting, I think.
Thank you. I think it's been hard on everyone. I think it's been harder on the frontline staff. Things probably became more amplified. And I say this because obviously for some studies that lost funding, many of the staff had to go home. We were lucky not to be affected in that way in many of our studies because we were able to negotiate for additional funding for research that was able to do that. It was good, but some of the research were not able to do that. And of course, that had impact not only at their personal level, but also a continued income. As frontline research staff, we had to think very carefully about what activities needed to continue happening and what was not possible to continue because of obvious the transmission and the exposure to staff. but also what we recognized very quickly, and it's again goes to working these kind of healthcare systems, being very much embedded within the healthcare systems, was that if we did provide, for example, for PPE for our staff, and they are working alongside healthcare workers who do not have access to that PPE, it was also causing tensions. And so institutionally, we were then bound to also think about the Minister of Health staff and how we are going to respond to that, so we don't cause these stark differences. That, of course, had budgetary implications, that had, all those other ripple effects. In addition, also the emotional, psychological support, many of the community members, populations, people who didn't know much about COVID, saw our staff, including frontline workers, as the sources of information in the midst of all the misinformation that was happening. So not only are they also being put on in situations that they might not have all the responses. Working with the engagement team, where the engagement team here worked very hard to provide basic information for every staff that they could draw on, and provide hotline numbers that they could call at any time. And that was really very helpful. And we can also talk about other systems we are using to help the staff, including researchers who are really facing quite challenging situations in the front line.
Thank you. I see Laura Hammett has a question, and Laura, I think you should be able to unmute yourself if you'd like to speak.
Hi, can you hear me?
We can.
Great. Thank you for a wonderful talk, Sassy and Dorcas. I actually had the pleasure of being able to work with Sassy and Dorcas when I used to live and work in Kalifi, and now I'm at the Hopkins Center for American Indian Health. And I had two questions that I wanted to ask your thoughts on. I think PIs often operate in a very siloed manner, and particular PIs may not have expertise in supporting frontline staff in the ways that you have outlined. And I'm wondering if you have thoughts or guidance about how, large institutions can try to implement some of this support and provide that in a more uniform way, rather than a sort of, does a particular PI have this interest or this capacity? And then the second one was just about silent refusals, which I think is common in many marginalized populations, and just more about the guidance that you've ended up figuring out to provide to frontline workers about that, and the activities maybe that you found the most helpful in terms of community engagement to increased consent acceptance and understanding, so that silent refusals are less of a concern.
Great, thanks.
Thank you.
Laura, do you want to go first, Dorcas?
Yes, I could. So there are several questions. I picked out 3 questions, Laura. Thank you very much, and great to see you in this. It's so exciting. Can I just talk first about the silent refusals, because that's an area that I not only studied it, but I experienced it, and it took me a while to realize that's what I was experiencing in my own research, conducting research in the front line. And in a way, I became then, I think, sympathetic to field workers who might be experiencing a very similar situation. The kind of guidance we try to do, we were keen to pick out. The first thing is understanding why the silent refusal is happening. In my case, it was a way to gain access to study benefits, but also choosing which study procedures somebody is comfortable participating and which one they are not comfortable participating, and therefore just not. And it is frustrating for anyone, because they are not saying no, but they just miss out. They miss out, and they have every reason, and a very credible reason, for not turning up when they don't want to take a nurse or swab, or they don't want blood to be drawn, but they'll turn up when there's an interview or there's something else happening. So they are choosing which procedures they are going to participate, and that maintains them in the study throughout. And then their children are taken care of by the study throughout that period. So it was agency being exercised, but also putting the research at a very vulnerable population, at a very vulnerable position in terms of how then you negotiate this. We came up with the guidance, and one of it was I mean, a very practical one. You go to, you follow up somebody 3 times, they are not turning up, that's okay. You know, you let it go, and you need to keep on emphasizing that research is voluntary. That, of course, meant that recruitment had to be far much higher, anticipating higher dropouts over time. And I know there were costs to research, but then that's something that researchers can work with and include in their budgets whenever they are looking for funding. More importantly, is there support to frontline staff. And what we've done institutionally, streamlined this so that we've got, what we talked about, communication, training, that also has got ethics aspect in it, that also has consent processes, including field workers themselves sharing the dilemmas they face in the field and how institutionally they can be supported, but also by the specific study. And we create forums where, when this sharing is happening, is at a place where the social science researchers can become the moderators of the conversations. So it brings the PI and the study coordinators and the field workers in the same platform to share the experiences in the field. The other thing that has been done institutionally, and this is also touches on engagement, is for every study that has got, that is happening in the community, to create what we call an advisory group. That consists of field workers from that study, engagement staff, and also a social science researcher, as well as a PI and the coordinator. And that is just a space for sharing whatever they are learning. They can come in with a question, the study team can ask us questions, we can respond, we can also share what we are learning from the field workers and so on. I know there are many others, but these are just very quick tips that we ended up using.
Thanks very much, Dorcas. Sassy, we're running at the end of our hour here, but I don't know if you have any thoughts on that last question yourself. You're welcome to offer if you do.
I know that we're over time, so I won't add to that. I think those are great points by Dorcas. And just to mention in relation to the COVID experiences, I mentioned the Global Health Bioethics Network as embedded empirical ethicists working in different contexts. And we're hopefully publishing a paper soon, just reflections on being a network, opportunities and challenges under and in response to COVID-19. So that might be of interest to some people here.
Great, thank you very much. Dorcas, I see one comment in the chat requesting a link or details to, I think you mentioned a paper about defining the concept or unpacking the concept of vulnerability. If you have time to drop that in there, I think it'd be appreciated. Otherwise, welcome to send it to me and I can pass it along to Winfred. But with that, I think we'll have to close up for today. And thank you both again for joining and sharing your really important and interesting work over the course of many, many years, I know. So thank you very much on behalf of everybody. And I'm sure everyone would be applauding if you could hear them. But thank you.
Thank you very much for the opportunity. Much appreciated.
Thank you.